Good evening, and welcome to Doctors on Call. I'm Dr. Ray Christensen, faculty member from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School here on the Duluth campus. And I'm a physician at the Gateway Family Health Clinic in Moose Lake. I am your host for our program tonight on cancer, prevention, diagnosis, and treatment. The success of this program depends on our viewers. So please call in with your questions or email them to ask@pbsnorth.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Matthew Braithwaite, an oncologist with Essentia Health, Dr. Roberto Fernandez, an oncologist with St. Luke's Regional Cancer Center, and Dr. E. Tolga Hanhan, a family medicine physician at St. Luke's Lakeview Medical Clinic in Two Harbors. Our medical students answering the phones tonight are Lindsay Montag from Sauk Rapids, Minnesota, Mackenzie Peterson of Laverne, Minnesota, and Alexandra Wollner from Montevideo, Minnesota. And now on to tonight's program on cancer, prevention, diagnosis, and treatment. As I start the night, I'm going to take just a personal moment, and on behalf of the university and Linda Liskowitz, who is the person that really makes this program happen, thank Dr. Greg Grell for his many, many years as the producer of this program. This has been a great relationship, and it's been really a lot of fun to work with him. We wish him very well in his retirement. And also a welcome to Nina Fredrickson, who is going to be the producer going forward. To both of you, thank you very much for all the work that you've done for WDSE, for Northeastern Minnesota, and for those of us at the university. Tonight's topic is pretty big and pretty wide. It's pretty hard to figure out how to put our arms around it, but Dr. Hanhan, what is cancer?
I think at its most basic level, it's cells that are basically growing and don't stop. I mean, if you think about how the human body is developed, we all have messages in our cells. When does something stop kind of dividing? Pick any organ, the eye, right? There's cells that make up the eye, and at a certain point, those cells just stop dividing. And because of various kind of crossed messages, that can go haywire. And some cells start dividing and growing, and that can cause problems in the human body, and it can be in many different organs, as we're going to talk about tonight.
Tell me a little bit about your practice. I forgot to ask you that.
Yeah, so I'm a family doctor up in Lakeview Clinic in Two Harbors, and we have a hospital up in Two Harbors as well. So I practice in that hospital as well as in clinic, and we do a lot of primary care. We talk a lot about cancer screenings when people come in for their physicals and whatnot.
Dr. Fernandez, you're an oncologist at St. Luke's.
Correct.
Tell us a little bit about your practice, and then maybe if you could stray on after that and talk a little bit about the diagnosis of cancer.
Yeah, sure. Thank you. So I work at St. Luke's Regional Cancer Center, and I have this will be my 5th year. I'm originally from Iowa. And you know, it's been a great place to live here in the Northland, so I really do enjoy it. I'm a general oncologist, so I do see a lot of different kinds of cancers, including leukemias, lymphomas, and solid tumors, as well as a bunch of blood disorders, including benign blood disorders. But specifically for cancer, you know, diagnosis of cancer can be very challenging at times, other times maybe more straightforward. It's reliant often on screening for cancer, at least for some cancers. And when we're able to catch cancer early, it can be curable in some cases. However, it can be more challenging if the cancer itself is aggressive and difficult to treat, or if there are limited treatment options, as we'll talk about. But the diagnosis of cancer, it takes into account, you know, the patient's history. They have to typically undergo several tests, including biopsies, often of various tissues, or blood testing, and then the results of that, you know, go through several different pathologists and laboratories, and then we tend to discuss that with them in our consultations.
Dr. Braithwaite, you're an oncologist with Essentia.
Correct.
Tell us a little bit about your work, and then if you take us into the treatment a little bit, kind of
Sure.
open that door up for us.
Yeah, thank you. So I think the work I do is very, very similar to Dr. Fernandez. I'm a medical oncologist as well as a practicing hematologist. I'm relatively new to the Duluth area in the Northland, having moved up here this summer and started working at Ascension in September. So like Dr. Fernandez, I see patients with a variety of cancers, and I also see patients with both cancerous and non-cancerous blood conditions. My clinic is largely here in Duluth, and I also see patients kind of down the I-35 corridor that get treatment in Sandstone and Moose Lake 1 day a week.
That's a nice broad background. Let's talk a little bit about what's a good lifestyle. We talked a little bit ahead of time about lifestyle and the importance of early diagnoses. You're the family doc, Tolga. What are your thoughts for a good lifestyle for a person?
Yeah. Boy, if there's one thing I think we could do in our lives to prevent cancer from happening in the first place is avoiding tobacco. Tobacco is one of the bigger causes of cancer, and many different cancers. Actually, it stems well beyond lung cancers. So avoiding tobacco, maintaining a good weight, so living a healthy lifestyle, eating well, and probably limiting or avoiding alcohol as well. So substances do play a role in terms of cancers.
Dr. Fernandez, how does alcohol factor in with cancer?
So it's complex, but ultimately excessive alcohol can affect the liver in many ways, and the liver is one of the body's filters. And over time, if that is damaged or you develop excessive weight due to the excessive alcohol use, then those fat cells can also release various chemical mediators which can put a patient at risk down the road of developing cancer, which is also known as carcinogenesis. And so it's a substance in very small amounts that is typically okay, but when it's excessive, that can lead to various problems, and not just cancer. It can also affect a person's risk of cardiovascular disease, heart attack, stroke, and various other issues.
One of the people that called in has a spot on the liver. How would they go about getting that checked out, Matt?
Yeah, so I assume at this point, they found this spot on the liver based on an imaging study, like a CAT scan or an MRI or an ultrasound. Sometimes different imaging modalities can give us a good idea of what that spot might be. So certain cancerous lesions and non-cancerous lesions can look a certain way on the image. But in a lot of cases, to know what something is for certain, it requires a tissue biopsy where a radiologist or proceduralist would maybe use some imaging guidance to direct a needle into that spot in the liver, remove a piece of that tissue, and send it to the pathology lab for them to look at under the microscope and come to a more definitive diagnosis.
Tolga, have you seen changes in the liver tests? Now that we're talking about the liver a little bit, it seems like there's been a kind of an increase in some of the enzymes, and those of us that are overweight, there's the question of fatty liver, and then how does that relate into the possibility of a liver cancer?
Yeah, so when liver enzymes are elevated, oftentimes that's just due to inflammation. And you're right, I mean, if you're overweight, that inflammation can be from excess fat by itself. And inflammation in general can promote various cancers of many different parts of the body.
Roberto, I see you nodding on this one. You want to add in?
Yeah, so we know, for example, with liver cirrhosis, that can predispose to hepatocellular carcinoma, also known as primary cancer of the liver. But interestingly, fatty liver, as you mentioned, or hepatosteatosis, that can also predispose, I want to say anywhere between 7 to 10% can directly evolve to primary cancer of the liver too. So it's important to maintain a healthy weight for that reason also, because often that can be reversible if you're able to intervene early on with lifestyle modification.
Matt, you're the hematologist. Well, I guess you both are.
Both.
Yeah. I shouldn't.
You can give him all the hard questions.
Okay. You guys can fight over this one. This person has myeloid leukemia. What is the long-term prognosis, survival rate, and talk about it a little bit. What is myeloid leukemia in the first place?
Sure. So myeloid leukemia is a fairly aggressive type of blood cancer that arises from the myeloid cells in the bone marrow. It typically progresses very quickly and can be a medical emergency when initially diagnosed, and the need to start treatment right away is usually pretty crucial. It can be a very challenging disease to treat. We treat it with the goal of cure in certain patients that are candidates for intensive chemotherapy. For many years, we didn't have a lot of options to treat these patients that weren't candidates for aggressive therapy, but over the last few years, we have other drugs that can treat acute myeloid leukemia and help give patients more time, though these treatments tend to not be curative in nature.
Okay, you guys comfortable? Two Harbors, so I'll pass this one to you. Why is pancreatic cancer so difficult to diagnose until its later stages?
Yeah, that's a great question, and it's very problematic. So we do not have a screening modality for pancreatic cancer. It's one of these things where by the time somebody has symptoms, be it abdominal pain, weight loss, or other GI problems, oftentimes the tumor is too big. And by that time, it's really, it can be quite problematic because by then, oftentimes we're past the point where it can be surgically removed or treated very effectively. So it does have a very high mortality rate. But when we catch it early, it's usually almost luck. It's caught on some image. And if it's small enough, then yes, we can take care of that surgically. But most of the time, we catch it when it's really too late.
Roberto, what are effects of chemotherapy? Start over. Are the effects of chemotherapy cumulative with more treatments over time? Or
yeah, that's a good question. I think some of them can be, certainly. There are definitely long-term effects of chemotherapy. There are rare adverse events that can occur through just from being exposed to chemotherapy. They're rare and uncommon, but even secondary cancers can sometimes occur less than 1% of the time in patients who've been exposed to chemotherapy or radiotherapy for that matter. But the things I think about more commonly long-term would be cardiovascular disease, cerebrovascular disease. In the short term, we think about things like nausea, vomiting, diarrhea, fatigues being very commonly described. Patients will often wonder if they're going to have hair loss, and whether or not they're going to be able to go about their daily routines or continue to work, that sort of thing. And so it does depend on a lot of factors: the patient's age, their comorbidities, other medical conditions, something called performance status, so their ability to take care of themselves at home independently. And you put all of that together to kind of assess how they're going to be able to tolerate the chemotherapy. And some patients, will fly through it with flying colors. I've had patients in their upper 80s, even early 90s sometimes, which they surprise you with their ability to tolerate chemotherapy. Others in their 20s may have terrible, side effects, and it's so hard to predict. And we don't know unless we try, but we have great medications these days to help prevent a lot of the side effects and to support patients when they do develop side effects. And if we have to, we can modify the doses or the frequency of how we give the chemotherapy, because it is, one of the types of treatments that are effective in treating cancer.
Matt, comments?
No, I think Roberto really nailed it on the head. There are side effects that we see, that can happen just with one dose of chemotherapy, and others that can happen as accumulation as each dose is given that become more common. So I don't think I have too much to add there.
I think the other thing is that it's changed a lot over the decades.
Mm-hmm.
I go back to when I started practice a long time ago, when we used to hang 5FU on the valance on the window and run it in IV, to where you are today as you work on drugs and what you have, and then the outcomes that you're able to come away with. There's been a lot of change. Breast cancer has changed and is fairly curable, I believe, these days. Is that true?
That's true. A good proportion of women with early stage breast cancer are cured, and usually these are women where it's found confined to the breast and the surrounding lymph nodes, and we are able to thankfully cure many women with breast cancer.
Tolga, how much does patient choice play into overall treatment plans? And I give you that as a family doc, and you're probably going to want to pass it. But if I'm sitting in your office, what's that like?
Well, I think the biggest choice that we deal with in primary care, besides you're right, it's referral to see one of my colleagues here. But I think the bigger choice that some people will need to kind of decide which path they want to go on. And that depends on a lot of things, where people are in life, what their goals are for the rest of their life. But some people may choose, for example, to not seek treatment. And so I have a lot of conversations with patients about that. Do we want to pursue treatment, or do we want to pursue just working on making the remaining days of your life as good as they can be, just focus on quality?
Good answer, and I guess it's always nice to have your opinions too. What do you guys think on that one? Agree?
Yeah, I think Dr. Han, also, mentioned some really important points. We see patients every day who have a variety of, beliefs or values on how they want to be treated at the various points in their life. And so one of the things I always say is, you're the captain of the ship, you know your body better than anyone else, and our job is more to facilitate the information and share that with you and the evidence to help you make a decision that's right for you.
Matt, have there been recent advances in the treatment of prostate cancer?
There have been a number of advances in the treatment of prostate cancer. I think even, just in the last 10 years, the landscape has changed entirely. For men with metastatic or very advanced prostate cancer, the cornerstone of treatment has been depriving the body of testosterone, which we know is the main driver of prostate cancer growth. And so we currently have a number of different oral medications that work to inhibit testosterone's effect on the cancer in other ways. We have chemotherapy drugs that have been found to be very effective. And probably the biggest change within the last year or so has been a new drug called lutetium PSMA, which is available for men with very heavily pretreated prostate cancer. And this drug is a radioactive isotope where you give a patient a drug that has an antibody that seeks to find the prostate cancer cells, bind to it, and deliver a very focused dose of radiation to the cells. And so that's something that I think is very exciting.
It is. It's amazing. It's fun to read about.
Yeah.
There's been some great changes. Tolga, I think I'm going back to you. Skin cancer. How do you differentiate it in biopsy and so on? Do you want to just run through basic skin cancer?
Sure. I think the first thing is trying to protect yourself from too much UV radiation, sunscreen and avoiding tanning beds, etc. But skin cancers are a little tricky to find. Oftentimes they're found during a physical exam or just by yourself in the shower, and you just notice a little change in the skin. And so it's important to bring these things up to your primary care provider. And to a trained eye, for the most part, we can pick up something that doesn't belong, but we don't know it's really cancer unless we actually take it off the body and then send it to the pathologist to look at under a microscope. Oftentimes, they're small enough where we might just with this little razor blade-like device just scoop it all away, and that's kind of the end of it. If it's big enough or if we didn't get enough of it out at the office, the patient might need to go to a dermatologist or a plastic surgeon to have more removed with the pathologist in the room looking at it. the sample under a microscope as it's getting cut off.
Roberto, a change again. Family member has a blood disorder cancer from a JAK2 mutation. He's on a chemo pill. Could you discuss this?
Yeah, so JAK2 is a mutation. There are many. It's kind of an alphabet soup that we have to sift through as hematologists and oncologists, and it can be challenging to kind of explain that to patients also. But basically what it sounds like you're describing is a myeloproliferative disorder, or MPN for short. And if they are on a medication for that and they have a JAK2 mutation, if I had to guess, the chances are it's something called ET, which stands for essential thrombocythemia. And typically we start by using a drug called hydroxyurea or Hydrea, which is an oral medication. It's a type of chemotherapy. We use it for other blood conditions, including sickle cell anemia. But in myeloproliferative neoplasms, which do have a risk of evolving to acute myeloid leukemia, which we discussed earlier, this is a way to help control that condition before it makes that transformation.
Matt, what impact does chemo have on a person's teeth?
That's a good question. I think one of the most common things we can see sometimes in patients receiving chemotherapy are a risk of, oral or dental infections because of the immunosuppression that's associated with chemotherapy and its effects on wound healing. So sometimes when patients are needing very intensive chemotherapy where their immune system may be suppressed, we try and get them in to see a dentist if they need dental work done, to sometimes remove teeth that need to be removed or address some of these issues prior to them receiving some of these drugs that we know can lower their immunity.
Tolga, there's a question about nutrition. Why do we not use metabolic or nutrition to try to change and treat cancer? Seems like there's a lot of discussion about that, but it's really not used much, at least by us.
I think that's true. We know that it's important to have a healthy diet, maintain good weight like we've been talking about tonight. But there aren't a lot of strong studies that I'm aware of that link nutrition with curing a cancer, for example, or treating a cancer.
To the group, what are some symptoms that might indicate cancer?
Well, I would say the majority of cancers can be asymptomatic, so they won't have symptoms, unfortunately, and that's why we do a lot of screening tests for them. But in general, especially if you're thinking of some of the blood cancers like the leukemias and the lymphomas, we think of things that we call constitutional symptoms. And this could include involuntary weight loss, it could include shaking chills, high fevers that don't have any infectious explanation. Those tend to be the things I think about. Drenching night sweats, we call them, where they're changing the sheets every night. Those would be some of the classic symptoms, but some of the solid tumors, you may have the weight loss, you may have pain in some area, but it can be very vague, and so we don't always know until there's a screening test or a scan that incidentally shows something that they weren't expecting.
If I could maybe add one other thing, it's hard to predict what someone may have because cancer can really affect any part of the body, and so I think it's important for patients, if they're having a new symptom that is new, getting worse, or otherwise unexplained, they should be consulting with their physician or provider to look into that issue in more detail.
And keep after us if you don't think we're answering as we should. So that's important too. So one of you two, why is hematology specialty always associated with oncology?
I'll give a stab at it, and please weigh in as well, Roberto. But I think the roots of hematology have been linked with oncology because of the study and treatment of blood-based cancers, especially leukemia. So the pioneers of early chemotherapeutics were people that were treating leukemia.
Yeah, I would completely agree with that.
What are targeted drugs, Roberto?
Targeted
Got about
drugs.
30 seconds to a minute.
Broad category. It's hard to get me to stop talking. Sorry. Targeted drugs is essentially in reference to, we kind of mentioned mutations a little bit earlier. So patients can have what we call driver mutations, which you can think about them as driving the cancerous process within the body. And we don't know about every single type of driver mutation out there, but we know of many, and they've developed drugs that can actually pinpoint and target the cancers that express certain proteins or that have certain mutations. And so that's where that comes from.
Thank you. Great job, guys. I want to thank our panelists, Dr. Matthew Braithwaite, Dr. Roberto Fernandez, and Dr. Tolga Hanhan, and our medical student volunteers, Lindsay Montag, Mackenzie Peterson, and Alexandra Woolner. Please join Dr. Mary Owen next week for a program on influenza, pneumonia, and emphysema. Her panelists will be Dr. Jane Rudd, Dr. Sandy Stover, and Dr. Andrew Thompson. Thank you for watching. Have a great night.